So to continue on with our overview with respect to anatomy, very generally speaking, and how it's going to relate to osteopathic manual therapy and keeping our semantic network or our network of meaning focused on motion, now we are able to get into situations where we're talking about specific motions in specific regions. So we're going to talk about cervical flexion, right? So, or forward bending of the neck. Our main objectives here is going to first begin with a specific discussion of planes and axes to allow us to explain what flexion is, a specific discussion of the muscles that flex the neck, and we're going to compare that and contrast that with the muscles that flex the head versus muscles that flex the neck. We're going to have a specific discussion, as I already noted, of head versus neck flexion, and couch that in the concept of relational motion, or one thing stays still and one thing moves in relation to it. A general discussion of the neurovascular supply of the region, and a general discussion of areas to assess and treat should cervical flexion issues be suspected or reported by the patient. So to talk about planes, you have three cardinal planes, or the planes that people are going to talk about commonly. You have one that is going to cut the body in half left to right. So that is considered the sagittal plane. We have the horizontal plane, or the plane that's going to cut the body into top and bottom, relatively speaking. So essentially all these cuts can be made at 50% of the body, top left to right, top to bottom, or it can be made somewhere else, right? So you could have a mid-sagittal plane. So the true sagittal plane versus a mid-sagittal plane, or an off-center sagittal plane. You can call it different things. Then you have the frontal plane, which is going to cut the body in half, again, equally front to back. Now, those are the planes, and the motion is going to occur along the line of the plane. So if the plane goes this way, then the motion is going to go this way, right? If the plane goes this way, the motion is going to go this way. Right. Now, it depends on the type of motion you're talking about. If you're talking about translation, which really isn't a thing in the human body, you have more so rotation in a plane on an axis, or in multiple planes on multiple axes, or in a non-cardinal plane on a non-cardinal axis. But what you're going to have, so translation is one thing moving directly in a straight line, versus rotation generally tends to be, or a reasonable description would be, movement about an axis. So with respect to all these planes, the axis is perpendicular or at a 90-degree angle to the plane. So if you talk about the sagittal plane, perpendicular to it, so it's a sagittal plane on a transverse axis is usually the way that you'll see it said. The horizontal plane is also called the transverse plane. So there are times when you will use the name of the perpendicular plane, and there are times when people will refer to it in another way, right? So you can say sagittal plane motion or rotation in the sagittal plane about a horizontal axis or a transverse axis. You can say it different ways, but in net they mean the same. So that rotation is going to be forwards and backwards, right? So forward bending, or bending forwards, is going to be called flexion, relatively speaking. Another way to term flexion is closing of a joint angle, but you have to have a referential point to say it's closing, and generally speaking, that's the anatomical position. So a body is completely vertical or laying down, so it's kind of flat. Feet are pointing forwards, and palms are pointing forwards, and arms are at the side. That's your general anatomical position. So all closing of joints would generally be referred to that way. Or if you have a neutral position, you can call it closing of the joint with respect to that straight position. So with the elbow flexion is like this. With the knee flexion is heel going towards your butt. So it's kind of towards the back, but that's considered flexion. So it's closing of the joint. So you need your reference point, and they're not always standard, but a joint angle getting smaller may be a better way to say it. So we have in the sagittal plane extension, or backward bending towards the back of the body. And in the sagittal plane, we have flexion, or bending towards the front of the body. Now in osteopathy, you're going to have some people who like to be really confusing and talk about, I believe it's Fryat flexion. I may be misquoting that. I may be pointing to the wrong originator of the idea, but essentially you have closing specifically with respect to the vertebral column, kind of closing of an arch or opening of an arch. So it's regional flexion versus regional extension. That's confusing. Nobody talks like that outside of people who are talking about that one particular individual and how they say things. So we will use flexion with respect to the vertebral column to talk about tipping or bending towards the front of the body, and extension to talk about tipping towards the back of the body. So lots of words to set this up for when we do subsequent talks. And we have a baseline for the sagittal plane. We'll do the same thing with respect to the horizontal and frontal plane when we move past extension in the next talk, and we move towards cervical side bending and cervical rotation. So as far as flexion, which muscles are going to flex the neck, generally speaking? So the muscles that we're going to talk about, now we're going to have to make a differentiation here because some of them may do some cervical flexion, but realistically they're considered head flexors. Whereas some of them, one of them will flex the cervical region, but extend the head, depending on what you read. So generally speaking, what we're talking about is the rectus, right? So the rectus on the front of C1 and C2. So rectus capitis, it's rectus capitis anterior, I believe, or I may be messing that up, and maybe rectus capitis superior, but if you look that up a little bit more accurately, you can be 100% sure. So, and when I get to a subsequent slide, it'll be noted properly. So I will clear that up when I get to that slide. It's just not in my memory at the moment. Rectus capitis lateralis, you're going to have longus capitis, longus coli, and then the anterior, middle, and posterior scalenes, and you're going to have the SCM. These are all muscles that would be considered at least somewhat to contribute to head flexion or neck flexion, generally speaking. So if you're going to look up the group for most of the neck flexors, you're going to look at the deep cervical group, right? So the deep cervical group is considered to be anterior to the vertebral column, but within the neck. And that is going to be your rectus, so your rectus capitis, the two that I noted, and I will clear up for sure. Longus capitis, longus coli, capitis being head, coli, I believe, being neck, but my Latin isn't perfect. And then the scalenes, the anterior, middle, and posterior scalene, going from lateral portions of the neck to ribs 1 and 2, depending on which scalene you're talking about. The SCM going from, so it's the sternocleidomastoid, mastoid being the mastoid process of the temporal bone, the cleido being the clavicle, and the sterno being the manubrium, or the top of the sternum. Right, so capitis equals head. So rectus capitis anterior, as I said, I clear it up. Rectus capitis lateralis and longus capitis. So again, capitis being head, what we do is talk about head flexion here. So head flexion is the head tipping forwards relative to a still neck. So the neck has to be still to talk about head flexion, versus cervical flexion, the body has to be still and the neck has to be tipping forward, or the cervical vertebrae as a unit or group have to be tipping forwards. So we have that distinction. But rectus capitis anterior, lateralis, and longus capitis, when moving in a united fashion, when bilaterally contracting, will tip the head forward on a relatively still cervical column. It's at least possible that they could have some impact on cervical flexion because they do attach to the anterior portions of cervical vertebrae, but their contribution is likely low, if non-existent. So again, head flexion is tipping of the head forward, or the skull forward, on a still neck. And then the cervical flexion, neck flexion, is cervical vertebrae tipping forward on a relatively still body. So SCM can do that because it attaches to essentially a large portion of the neck, but not necessarily the cervical vertebrae, right? So it can pull stuff forwards towards its inferior attachment, but it is noted to extend the head or tip the head backwards on a relatively still neck, but it can broadly pull everything forwards. The other deal is that your anterior, middle, and posterior scalenes attaching to ribs 1 and 2, but also to the transverse elements, slightly anterior as well, but those transverse portions of the cervical vertebrae can pull to their inferior attachment from their superior attachment. So you'll get that cervical flexion on a relatively still body. So the sternum, the clavicle, and the first 2 ribs are your anchor points for pulling the neck forwards actively, and then gravity can do some degree along with that. Now the head can tip backwards while the neck tips forward. So you can have head extension and neck flexion. You can have head rotation and neck flexion, head side bending and neck flexion. These things can all occur, which is what allows you to understand, at least superficially from the outside, that there should be some discussion of the difference between the movement of the head on the upper cervical complex against a relatively still cervical column and the movement of the cervical column in relation to a still body. Now, if we're talking about your neural supply, if you're talking about the scalenes, depending on the resource that you grab, you're going to see different anterior spinal or the anterior rami of the cervical spinal nerves, and you're going to see different levels noted. Some will be as high as C1, some will be as low as C8, some will be somewhere in the middle. But generally speaking, it's the anterior rami, and you're also going to get that with respect to the longus colli and capitis. It's the anterior rami of the spinal nerves. They're not necessarily directly related to the cervical plexus proper, but they would be from similar nerve roots as the cervical plexus proper, as well as the brachial plexus proper. But because of where the muscles are, they just get the anterior branches of those spinal nerves. It'll send off in varying individuals in varying ways. It'll send off some of those anterior roots before contributing to the cervical or brachial plexus. And then you're also, with the SCM specifically with respect to neck flexion, you're talking about the spinal accessory nerve, which is cranial nerve 11. The spinal accessory nerve is going to provide neural tone to, or motor tone rather, to the SCM and the trapezius. So there are multiple actions for that one nerve. So the trapezius basically being shrugging, right? So if somebody asks you, what does the cranial nerve 11 do? And you do this, right? Or you do something like this, you can get the answer. Like it's a way to create your semantic network. Or you could go like this. You could drop the head, look up, and shrug. And that's the accessory nerve, or the bilateral actions of the accessory nerve. So you, generally speaking, you're talking about, again, for head flexion and neck flexion, the anterior rami of the spinal nerve roots to all of these muscles, aside from the SCM, for generating active head flexion and neck flexion. As far as the vascular supply, you're speaking mostly on the arterial side of branches of the external carotid, the thyrocervical trunk to some degree, and the costocervical trunk, if I remember properly. So you're going to get some blood supply to these muscles, mostly off of, the easiest way to put it is off of the subclavian and branches thereof, but the costocervical and the thyrocervical, as well as the external carotid, and to some degree, depending on which resources you read, talking about longus capitis, longus colli, you're going to get some branches from coming forwards off of the vertebral arteries. So the vertebral arteries are generally believed to not supply anything on their way up, but it's possible. And some resources would suggest that some muscles will get supply from the vertebral arteries as well as the other paths. But generally speaking, you're looking at carotid circulation, especially external carotid circulation, as well as circulation off of the costocervical and thyrocervical trunk. I'm not 100% sure if I'm calling the costocervical trunk correctly, but that is available in multiple resources. As far as vascular drainage and lymphatics, you're looking at the lymphatics of the head and neck. You're looking at the internal and external jugular circulation and all the branches thereof. But with respect to the movement itself, if there is a drainage problem, you would generally trace the SCM and the clavicles and the upper ribs and the scalenes. So that's why you would trace the upper ribs, because of the scalenes, and because if memory serves properly, the jugular, or rather the subclavian vein, is between the SCM and the anterior scalene, and then the subclavian artery passes between more or less the anterior and middle scalene. So you've got some relationship there between ribs 1 and 2, the SCM and the scalenes. So you would track those things in order to do something about supply or drainage. As far as the lymphatic drainage, again, you'd be tracing the SCM. All right. So once you get above the clavicles or into the neck and up, your considerations are almost always going to be the same with respect to, from the outside, based on motion, how you would interface with these things in a meaningful way. You'd have to find a motion problem, you'd have to deal with it, but the places that you're going to have access to the possible culprits are going to be almost always the same. So the cervical vertebrae generally, the upper cervical vertebrae in particular, for head movement, the SCM is a major highway with respect to many of these vascular pathways and these neural pathways, and the clavicle and upper ribs also have large impact. All right, now areas for assessment and treatment, as we already noted, your upper ribs with respect to the scalenes. The scalenes have particular relationship with the subclavian artery, the subclavian vein, as well as the right lymphatic duct, and on the left, the thoracic duct. So those are terminal drainage points right about here. Then you're going to have the clavicle itself with respect to the SCM, but as well, at least on some level, the neural and vascular pathways. Again, if there is a motion problem that relates well to the symptom or the sign that you would have identified or maybe didn't identify, then you're looking at these areas, because if you change the motion and the symptom or the sign change, then you have at least a tenuous relationship that's going to be positive. And then the cervical vertebrae, generally speaking, as already noted, and then the head on the neck, right? So our movement of the head on the relatively still neck. So all of these things will relate well to where you would expect to find problems in relation to neural tone, vascular supply, or drainage with respect to issues with cervical or head flexion. Now, just a general note that will set this up for many other circumstances is if there's a problem with flexion, right, problem with active flexion or even passive flexion, is very unlikely that the culprit of that is the neck or head flexors. It is more likely that it is some combination of head extensors, because in order to go forwards, right, so if we talk about reciprocal inhibition, so in order for joints to move smoothly, then if for one side to move, the other side has to relax. Now, this isn't perfect in all circumstances, but it's a general enough concept that is useful to us. So when these contract, the ones on the back have to relax to allow the movement to happen. So whether it's active or passive, because actively you could have tension that is mediated by some form of neural reflex, and passively you can have the same thing, right? So depending on how it's done, you could have it be a a muscle spindle reflex or a GTO reflex. The GTO reflex is going to be more about speed of change of the length of a muscle. So if you're going slow, you're not likely to identify a GTO reflex, but if you are going slowly, you might get to a point where tension may increase because of a muscle spindle mediated reflex. Now, again, not perfect, but it's at least something superficially we can point to make the claim or make the concept clear that when you have a problem with flexion, the extensors are probably the issue. So you would want to consider the extensors in order to fix a problem with cervical flexion. So if cervical flexion is limited, you would work on the cervical extensors, or consider the cervical extensors the likely culprit until proven otherwise. If you had a problem with side bending left, then the side benders on the right side would be the culprit. If you had a problem with rotation right, then the culprit would be the rotators on the left. Now, you have to have some degree of understanding that many of these structures are redundant, right? So side bending, you can have the SCM somewhat related to side bending, flexion, and extension of the head, right? So extension of the head, flexion of the neck, and some degree of side bending and rotation of the neck broadly are all the SCM, but it would be one SCM versus the other once you go off of the sagittal plane. So there is some redundancy, and that will be made clear over time through this project. And that redundancy is useful because it allows us to really deepen the meaning and the understanding that looking for a particular muscle may not be the best way to do it. Looking at a particular motion and understanding that the problem with the motion is just probably on the other side of that motion will help you understand where to look and why to look there.